Hi, my name is Timothy, and I'm a PhD student in the Department of Medical Biophysics at Western University. And I work with Drs. Bauman and Yartsev and a number of scientists across the City of London. Medical imaging plays an important role in cancer diagnosis and treatment. It tells us where a tumor is located, and this can be used to guide treatments like surgery and radiation. With that said, we don't have a good idea about how a tumor reacts to different treatments. This is like looking at a person but not knowing his or her personality. The good news is that today's medical imaging technologies will let us look at how a tumor behaves before and after treatment. We can look at things like tumor metabolism and blood flow. This is important because this can potentially provide physicians with the capability to monitor how a tumor reacts to treatment. A physician can potentially switch to Plan B if Plan A doesn't work. This is what my research is about. My research focuses on using different imaging technologies, such as perfusion imaging, to image brain cancer blood flow and to follow how the tumor changes after therapy. We talked about what is a clinical trial and why we do it. So how do scientists and clinicians take a drug that was discovered in the lab and deliver it to a patient at the bedside? Well, let us look at one example. Back in 1971, a world-renowned scientist, Dr. Folkman, proposed a new idea to treat cancer. His idea is called anti-angiogenic therapy. He proposed that if we cut off the blood supply that feeds the tumor by stopping new vessels from growing, we can treat the tumor by starving it. The quest to find a target that can stop blood vessels from growing began around that time. Between the years of 1983 to 1989, several scientific breakthroughs happened. Scientists identified a molecule called the vascular endothelial growth factor, and this molecule is responsible for regulating the growth of new blood vessels. Now, there was a target. By 1993, scientists showed that an antibody that acts on this vascular endothelial growth factor had anti-cancer effects in the lab. A human version of this antibody was developed in 1997, and Phase 1 trial began that year. A series of Phase 2 trials started in the following year, and a Phase 3 trial was completed in 2004 for patients with metastatic colorectal cancer. And this antibody became the first approved drug to target tumor blood vessel growth. It took 30 years for this drug to become available to patients after it was imagined. Today, anti-angiogenic therapy is still an active area of research. Bench-to-bedside research is not just a one-way assembly line. It can be viewed as a cycle where one area of research can be the driving force of another. Questions raised by clinicians can potentially be brought back to the lab to be studied. For example, clinicians are continually looking for new treatment targets to improve patient care. This drives the need to test new treatment in labs and also the need for using innovative technologies like medical imaging to assess response. New treatments and technologies will then be tested in clinical trials. Future healthcare professionals will hopefully have a larger arsenal of treatment options and assessment technologies to help patients. I started doing cancer research while I was being trained to become a radiation therapist. And I do cancer research because I wanted to know more about this complex disease. My hope for the future is hopefully we'll have better imaging tools to help healthcare professionals and patients to select the best course of treatment.